At the ASH meeting, I moderated one of the sessions focusing on MRD in the context of heme malignancy, specifically focusing on ALL, CLL, multiple myeloma, and DLBCL. So I think the main highlights of the session, and again, it goes by the disease subtype. For example, for ALL, we already know that MRD is extremely important in terms of progression-free survival and overall survival. And what we also saw that there is emerging data with the use of next-generation sequencing with MRD sensitivity going as low as 10 to the power minus 6. And it appears that those patients who are negative at 10 to the power minus 6, their outcomes are better. They're less likely to relapse if you achieve 10 to the power minus 6 negativity, as opposed to patients who are positive at that level. Similar data has been reported now in the context of CLL. Traditionally, the criteria for MRD, which is used in most of the studies, is a sensitivity of 10 to the power minus 4. But again, with the use of next-generation sequencing, what we are seeing is that patients who achieve MRD negativity at 10 to the power minus 6, it appears that those will less likely to relapse long-term as opposed to patients who are positive at that level. Again, similar data is coming out in multiple myeloma, where, again, MRD is becoming increasingly important as part of endpoints of clinical trials. And we also, in that symposium, discussed for DLBCL, use of circulating tumor DNA as a assessment for MRD assessment for these patients. And there is data out there in the DLBCL field where measurement of circulating tumor DNA relates to a clinical outcome for these patients. And studies have shown also that ctDNA levels a few weeks after starting therapy can really very nicely predict long-term outcome for these patients. So the field of MRD continues to evolve rapidly, and I think that was some of the highlights from the meeting.